There's been a lot of buzz, and there is a lot of buzz about AI in surgery. And so what Dr. King and I will try to do this afternoon is talk a bit about not the technology, but what it can actually provide us and the value that it can provide us as we provide patient care. So let's start. My name is Tamir. I'm an MD PhD, and I founded Theator a few years ago. And this slide is actually going to talk a bit about why I took the time to found a company. There is, and we've heard a bit about it throughout the day today, there's unacceptable variability and disparity in surgical care today. This is out of a paper published in the Green Journal last year that showed that in a single healthcare enterprise in New York City, so not somewhere else around the world, but in New York City, low socioeconomic patients are routed to low volume hysterectomy surgeons that perform procedures in an open way, as opposed to high net worth individuals. And that was connected to increased risk of perioperative morbidity and mortality. There's a lot to unpack here, but what I want to focus on is how we actually leverage technology in order to tackle this, in order to unearth, disseminate, and ensure best practices across the board, because ultimately this notion of where you live and how much you make shouldn't really determine if you live. But how do we even know what best practices look like? Today we have really good understanding of outcomes. We have very limited understanding of process in the operating room. And so what we set out to do at Theator is first and foremost start to routinely capture everything that is being done intracorporeally in the OR. And not only do that, but connect the dots along the patient journey. So who is the patient that goes into the procedure, what is actually being done in a procedure, and then outcomes. And connecting these dots is extremely important if we really do want to be able to unearth what best practices look like. So as we started out, we realized that one of the most important things to do is to really base all our understanding on the ground truth. We all know the shortcomings of the operative report. If you take a look at 5 patients throughout the day, unless something horrific happened, they're pretty much cookie cutter template, the same thing across the board. But on the other hand, if you routinely capture video intraoperatively, in all the procedures that we do minimally invasively, whether straight stick or robotic, we can actually unearth so much. So this is an example in general surgery of a gallbladder, like the most common procedure that's done, I think, minimally invasively today. And in a few seconds, there's going to be transection of the common hepatic. This moment is lost forever today if procedures are not routinely captured. We obviously don't go in a procedure knowing that something bad is going to happen. And this moment is lost for more efficient handoffs, quality initiatives, safety initiatives, debriefs, what have you, GME. There's so much that can be learned from all these moments that are lost every day on our OR floor. And so this is really fundamental, the ability to routinely capture everything that's done. But if we capture hours and hours of surgery, how do we make sense of it? And so this is sort of the deep technology stack that we've been working on at Theator over the past several years. And what we've done is we've gone ahead and automated identification of a variety of aspects of surgery, a variety of moments. The most foundational and fundamental are the routine procedural steps that occur in a given operation. Events that occur during a procedure, like leaks and bleeds, etc. Safety milestones are these specific moments in time that you need to achieve with safety views in order to proceed properly in a given procedure, and automating identification of complexity of a procedure, because not every patient is really alike. And when we're able to automatically identify this and do this in a wide variety of procedures across hundreds of procedures in a variety of specialties, we're then able to start understanding what is actually being done in a given procedure. And everyone talks about AI and everyone talks about analytics. And again, there's a lot of buzz around it, but what does it really mean? And so what I started talking about initially is this connecting the dots along the patient journey. So we now have a way of structuring or identifying key components intraoperatively. We then connect them to preoperative parameters around the patient, like BMI and risk factors, prior medical, prior surgical, etc., and obviously post-op outcomes. And then we're able to start coming out with both analyses and insights that can actually push the envelope on how we provide patient care. So similarly to elite athletes or in the Navy where I served for 8 years, the ability to assess, enhance, improve performance continuously is really dependent on our ability to take a very deep dive and assess what we're actually doing, which is not done today. So everything that we're doing at Theator is really spanning across what you see here, capturing information routinely, structuring it, then analyzing it, and ultimately deriving insights. And I'll give you a few examples of where we're going with this. So here is an example, again, not from gynecology. This is the longest procedure we've been able to automatically annotate. It's a robotic Whipple, an 8.5-hour procedure. So imagine that you come out of that 8.5-hour procedure and you want to review it efficiently. Everything on the right-hand side that you see is automatically identified for you as a surgeon in real time, and you have access to this as soon as you scrub out. These are these critical steps of the procedure, events that occur, variety of milestones, complexity levels. Ultimately, we're starting to codify decision making, but the bottom line here is that you can break down a procedure into discrete moments that are really important. And within that 8.5-hour procedure, after 2 hours, this happened. This is a very experienced surgeon. Obviously, if they're doing robotic Whipple, but this happened after 2 hours. What you can see here is use of energy too close to the bowel and bowel injury. Now, today, this is lost. And even if it were captured routinely, like no one would be able to even like get to this point in time. Now imagine this patient goes back home and then 5 days later comes back to the hospital with post-discharge leak. How do you connect it to what actually happened and transpired in surgery? And so for the first time, we're able to understand the process. We're able to identify key moments that occurred during this procedure and connect it with outcomes. And if we do this at scale, not in a department, but within an enterprise, we're able to start deriving insights that can actually change the way that we provide care across healthcare systems. And this is an example I like to show out of gynecology, because this is really one of the first times that we've been able to demonstrate identification of best practices and dissemination of them. And Dr. King will talk about a bit about the way that she views things in a few minutes. But if it is an acceptable parameter within the surgical community that deliberate identification of the ureter during hysterectomy is important, we need to be able to assess whether or not it's being done. And if it's not being done, we need to be able to encourage it. So what we created, and you can see it in the top part of this slide, we created an algorithm that automatically identifies in real time whether or not the ureter is taken a deliberate look at. And when we take a look, this is the bottom panel of, or bottom part of the slide, when we take a look at a department in a single institution, we see the histogram is the median duration of procedure, so one of the parameters we have today. That's obviously incomplete. But the numbers, the percentages, are actually the percent of time that each specific individual here takes a deliberate look at the ureter during hysterectomy. Now, when you ask the leaders of the department, before we showed this to them, like what percent of time do your folks take a deliberate look at the ureter? It's obviously, very high. But then when we take a look at the actual data, you can see here significant variability between individual surgeons within this department. But the really cool thing is what happens when you're engaging a department that is extremely dedicated to a culture of quality and safety. And so this is what happened over the next 4 months as they were engaged with our platform. We demonstrated an increase in safety milestone achievement. So 56% across the board started to take a deliberate look at the ureter. This was coupled to a reduction in intraoperative events. So the procedures went smoothly with the intent of doing things higher quality and safer. the actual procedure went smoother, so less bleeding, etc. And this was also coupled to a reduction in operative time. And I think this is really important because as we're being pushed as surgeons and providers to churn more patients in the operating room, it doesn't mean anything if we're doing it in a way that's not high quality and safe. And the ability to couple between increased volume of patients in a given operating room and quality care is extremely important. And this is where we're also starting to bridge this gap between surgeons and clinical leadership and administration, and start measuring what matters and actually acting upon it. So hopefully this connects the dots a bit to what I started out talking about. And I have the amazing fortune to have Dr. King here with me. I'll pass the baton to her.
Thank you, Tamir. Beautiful work. Do I need this mic or just this mic? Just this one. Thank you so much. It's an honor to join Tamir on the stage today. His company is doing such amazing things that I'm really excited to show what we can do with their platform, just within the realm of laparoscopic hysterectomy. So laparoscopic hysterectomy is really the language that a lot of us are speaking. It's one of the most common majors that we're doing. And within TLHs, when you break it down, oftentimes 9 main steps that I oftentimes scaffold these procedures in: port placement, put your manipulator in, abdominal survey, upper pedicle, lower pedicle, bladder flap, colpotomy, get the specimen out, and enclosure, right? I think we'd all agree that we all do these steps. And there may be a different order to these steps depending on what case that we're tackling, but all these things need to be done. And one of my passions is really breaking down these big procedures into deliberate steps. And my mentor, fellowship director, Dr. Ted Lee, really ingrained in our brains about these critical views of safety during different procedures. And the way my brain thinks about these is that really identifying anatomical landmarks, isolating key structures, and optimizing these views for upper pedicle, lower pedicle, colpotomy, all the important steps of a hysterectomy. They're really important to do. And my brain always goes to the place that until you have this view, you should not proceed, right? You need to find this view. For example, this is upper pedicle. The arrow below is ureter. There's a window between the IP and the ureter. And until you have this exact view, you should not proceed. Same with the lower pedicle in the picture on the right. We have the vaginal epithelium in the front, vagina shown in the back. We have our ureter lateralized, and we're taking that uterine artery 90 degrees. And that's really what we should be looking for. Now, when I'm teaching my fellows and residents, I'm making sure these critical views are happening, right? Or if I'm reviewing videos for my residents and fellows. But actually making sure this is going on throughout a department is impossible, right? And a lot of us are recording our cases, every single case, but actually going through these cases and finding these views on our own, it just isn't possible with our busy schedules. So really, one amazing thing that Theater is doing is really enabling us to identify these critical views using AI technology, taking manpower out of it, and then operationalizing it, right? So breaking these down, making sure that these steps are actually happening. If they're not happening, why? Looking at where surgeons are, where they want to be, looking at that delta, and moving surgeons into the direction of really mastering these steps of a major procedure such as a TLH. So in this example, the surgeon is looking for the ureter, and once the ureter is identified, you can see it vermiculate there in the retroperitoneum. You can see that it lit up on the side there. The AI caught it, the ureter was identified, and now we can track that, and like Tamir said, it won't get lost looking at it in the future. So in regard to the data that we have currently on the platform, there's about 460 TLH procedures that are uploaded from about 40 different surgeons from 5 different hospitals. And I want to next look at a couple different slides at the data that we've generated from these different surgeons. So what can we actually get out of this, right? AI is a hot topic, sounds amazing, but how is it actually changing practice, and how am I actually utilizing it to change practice? So one thing that we're looking at is looking at the adherence to actually identifying the ureter during a case. So we're gonna break that down, just as Tamir briefly just mentioned. We're also looking at significant events intraoperatively, right? So in this example is intraoperative hemorrhage. And then the last example here is technique variation. And this can be different parts of those different steps of a TLH. In this example, it's going to be bladder flap. So how do you actually break down the technique of different surgeons within a department, within an enterprise? So in this graph here, you can see that we have the adherence to actually viewing the ureter, and then on the horizontal axis, the time from when the scope went in to when the ureter was actually identified. And what you can see is that some surgeons, just like Tamir mentioned, actually didn't find the ureter. But if you asked oftentimes the chair, we're saying everyone's finding the ureter. Like, we're 100% finding the ureter. Why wouldn't we be finding that? But when you break it down, there's actually a cohort of surgeons that aren't really looking at it, or they're not finding it until an hour and a half into the procedure. And here you can see that hospital A is in blue, hospital B is in purple, and hospital A is really driving this adherence, but they are close to 100% at finding that ureter. And then you can break that down into what does that exactly mean in regards to intra-op complications, what does it exactly mean into post-op outcomes, right? You can break that down with data-driven metrics. This is another example of a surgeon with relatively high volume, right? So over about a course of a year, this surgeon was performing about 47 TLH hysterectomies. And this specific surgeon was finding the ureter at about 32%. So about a third of the cases, he or she was finding the ureter. The other cases, it was not identified. And within those cases, they found about 6 instances of intra-op hemorrhage. Really interesting, right? So higher volume surgeon, oftentimes we look at numbers as really being an indicator of somebody's skill, and that is important. We know that higher volume surgeons do typically have better outcomes, but here we can actually break it down into a really analytical way that even though the volume is high, the quality of him or her actually finding, I say him, the times they're actually finding the ureter is about 32%. And within that 6 intra-op hemorrhages, that's a pretty big deal. We can break that down and actually make movement to help change that practice. And this last example is the example of a bladder flap. This is a way we can really break down specific techniques within those steps, right? Upper pedicle, lower pedicle, bladder flap, colpotomy, vaginal cuff closure, uterine morcellation, breaking these down and seeing what's working well and what could be improved. So here in surgeon A, it took this surgeon about 15 minutes to perform the bladder flap. Now we all know there can be instances where there's been a couple different C-sections and obliterated anterior cul-de-sac. In this example, we can see it looks fairly straightforward, and it takes the surgeon about 15 minutes. Surgeon B, a little bit quicker, right? Surgeon B took this surgeon about 1 minute to create the bladder flap. And we can really break that down and look at what are the differences in technique, right? Well, why is one surgeon taking so much longer than the second? And what can we do to help close that gap? Right? So not only are we analyzing what the differences are, but then making an action plan to help close that gap and elevate care ultimately for our patients. That's why we're all here. And I always like to bring up a bit about the idea of surgical coaching, right? Data is really important, and we're getting flooded with a lot more data now, which I love. We're all oftentimes laparoscopic surgeons at this conference. We're already recording our cases. We like all these data metrics, but data alone isn't necessarily good enough to actually change performance, right? So data alone, important, but unless there's an actual conversation about that data, then oftentimes real improvement can't be made. So what I think is really amazing about Theator as well is that we're getting all of this data. We can look at that. We can look at our ideal state. We can look at how we can actually change these data metrics to improve performance, whether that be technical, non-technical communication skills in the operating room. So that being said, we have so much amazing work to do. We're all already recording our cases. Let's take those cases and actually take it to the next level. And how do we actually do this at a large scale, automated? That's really where the magic of Tamir's work is bringing us. With that, I turn it back to you, friend.
Thank you.
Yeah.
All right. Thanks, Cara. So I think we talked a bit about quality, we talked about safety, we talked about enhancing the way that we provide care within the operating room. Cara talked about the coaching aspect, which I think is extremely, extremely important. Let's talk a bit about where the future of this field, in our opinion, is headed. So everything, hopefully, that I showed you up until now, together with Cara, goes to elevation of the standard of care and obviously reducing risk, minimizing variability and disparity by being able to identify best practices and disseminate them. But there's also a component around operational efficiencies. So where do we go from here? Everything that we do today is really around routine capture of this information, this amazing ground truth source that is currently lost, the structuring of it and the analysis But all of this allows us to think, several steps ahead. And there's this thought process around the move to real-time decision support. How does that actually look like? So when we understand context and we do that in real time, we're also able to start providing insights in real time. And so at least the way we're approaching it is we're starting to provide real-time notifications outside the operating room. So Dr. King is at home and there's a satellite hospital in Cleveland that's performing a procedure that she wants to keep an eye on. She can have access to exactly what is happening in that operating room by being push notified, knowing exactly what happens in real time. Another example of this, and this isn't, this specific demonstration is not from gynecology, but you can all relate to significant bleeding happening in a given operating room when you're not there. And so the ability to actually take a look on a secure platform and have access to this is extremely important. And ultimately, all of this brings us to, I think, where we believe the future of the field is headed to. And this is another example from general surgery, but I think you'll all relate. Every single procedure that we have has a ton of decisions that we need to make throughout the procedure. And I think what differentiates a surgeon with a ton of experience from a novice, and from the best surgeons, from those who are on their way there, is the amount of exposure that we've had. And ultimately, the way that surgery has been practiced for hundreds of years, the apprenticeship model, is ultimately very limited. But what if we could provide in real time the guidance of thousands of surgeons and tens of thousands of cases? So in this example, what you see is a hyperemic gallbladder, and the decision that the surgeon needs to make is whether or not to decompress it. And so there's a decision that needs to be made, decompress or not. And today the surgeon does it based on his or her subjective experience. But the idea is to ultimately be able to provide a significantly larger N of experiences, those that opted to decompress, those that opted not to decompress. And to show that not only as a decision, but ultimately what the consequences of that decision ultimately is, whether it's length of a procedure or length of stay or bounce back rate or complication rate. And this is all, doable with technology. That is the power of a computer. And we believe that this really is the future, focusing on the cognitive aspects of intraoperative performance and enhancing the ways that surgeons perform, surgery and make their decisions during their operations. So thanks to everyone for joining us. Happy to continue the conversation and answer any questions. We're right across the hall. Thank you.